Welcome back to the Anja Health Podcast. Today I'm super excited to have Dr. Nadhee Sachdev, a reproductive endocrinologist and fertility specialist. You are our second fertility-related guest. And I'm super excited because last week we had your business partner and colleague on the podcast as well. So thanks so much for being here.
Oh, thank you so much for having me. I'm really excited to be here.
Awesome. Well, I'd love to get a brief background on your experience and also your affiliation with OC Fertility, and also feel free to do a plug on OC Fertility if you'd like.
Okay, cool. So my name is Dr. Nadhee Sachdev. I'm a reproductive endocrinology and infertility specialist. That's kind of fancy for fertility doctor. So I'm a California native. I grew up in the Bay Area. I went to college in Orange County where I practice at UC Irvine. So I went to med school at UC Irvine, and then I made my way to Chicago. I trained at the University of Chicago, and then I did my fertility specialty training in New York and the NYU Fertility Center. So I feel lucky to have been, as kind of as we were talking about offline, to have been able to train at such diverse places and just meet different people and different wide variety of things. So I practice with my colleague Sharon, who you had on the podcast earlier. I've been practicing with her for about 6 years at OC Fertility in Newport Beach. So we are, a simple way to say it, fertility doctors. So we help people get pregnant and help people who are thinking about getting pregnant, people who are not ready to get pregnant, and people who aren't sure. I love my job, and I love educating people about fertility and women's health, and I'm really happy to be here.
That's awesome. What attracted you to fertility as a field?
So I've always been interested in women's health. And so initially when I was in med school, I was like, I want to take care of a pregnant patient, because I just thought it was really fascinating how our body changes. And I got to residency at the University of Chicago, and I was like, this is awesome. This is great. And then I slowly realized that, even when people have less prenatal care, in many cases, people can still have beautiful, healthy babies. And I kind of realized, well, although I am making a difference at delivering babies, I would get to interact with people while I was delivering their babies who had a hard time conceiving. And just hearing their stories and hearing them talk about their journey to getting pregnant, I kind of realized I felt like the delta on how much of an impact I had on their life was a little bit greater.
Yeah.
When I was helping people get pregnant versus helping deliver babies. I mean, I enjoyed that, definitely. I mean, it's the only surgery you can do where you get a prize at the end. But no, that's kind of what got me interested in it. And then I started to do research in it and spend more time in it. And then I just actually was really excited by the science and technology.
Yeah.
A big part of what I do today in 2023 was actually still considered experimental when I was in residency from, 2010 to 2014, which is mind-boggling, right?
Yeah.
And so for me, growing up in the Bay Area, being surrounded by tech companies, the technology aspect of it was also really exciting.
Yeah, that's awesome. Wasn't the first baby conceived via IVF, it was only in like the 80s, right?
Yeah.
Okay.
So not that long ago. Yeah.
Awesome. Well, as you know, Anja Health does cord blood banking and placenta banking. So I'd love to get your professional opinion as an expert in the women's health field and a reproductive endocrinologist, what your opinion is on cord blood and placenta banking, and also just your general exposure to it as a physician.
Yeah. So I'll say, admittedly, the last time that I delivered a baby was almost a decade ago. It was 2014. But the majority of experience that I have from cord blood banking was from my time as taking care of women who are pregnant and delivering their babies from 2010 to 2014. And I would say that, it's expanded a lot. When I was delivering babies, there weren't that many people who were aware of it. And even as a general OBGYN, I didn't have really that much information to help educate people about it. So it's really changed because previously the mantra was that, well, it may not help this current baby, that maybe it'll help subsequent babies of your babies. But now, I think it's a really great option because, heaven forbid there is a health issue in which, one of your children needs their own stem cells. I think it's a really great option. And I think now with, more options available and more education out there, I think more patients might find it accessible and have a better understanding of what it is.
Yeah, I'm curious what your professional take is on stem cell research in general, because I've read some pieces around stem cells kind of being related to fertility. Like there's sort of like this far-fetched idea that we can sort of use stem cells to even create sperm or like things like that. So yeah, curious to get your take.
I mean, I think stem cell research is important for many things. I mean, I think, cancer, for other health issues, and even for fertility. I think that I don't think that we're that close to being able to create sperm from a stem cell. I know there's parthenogenesis and research of that sort that we're trying to do. And even when I was training at NYU and one of the research labs I worked with, we were working on that, but it's not that simple. And so while I think research is important and hopefully in the future we can do great things, I don't think, my concerns for that are not super high.
Yeah. I have this coffee table book where it goes over basically answering like the most far-fetched questions that people can have. And one of them is around how can someone basically have a child with themselves? And it goes through like the motions of like, if stem cell research was able to be like this grander thing where we can indeed use it to create sperm, then someone could potentially sort of fertilize themselves. So, it was interesting.
Well, it's also kind of like there's uterine transplants that are occurring, right?
Yeah.
And so kind of an ongoing, scary question I'd ask my husband and his friends are like, well, uterus transplants are happening. If we can transplant to men, would you want to carry pregnancy? Right. And so maybe that'll happen in the future.
Yeah.
I mean, I think it's kind of the similar conversation piece, right? Like it's theoretically possible, but is the science going to be there to happen in the next 20, 30 years?
Right. Yeah. Do you have a take on artificial wombs?
I mean, I think in terms of uterine transplants, I think that's an important concept, particularly for people who, have lost their uterus due to hysterectomies and things of that sort. I think the artificial wombs could show really great promise for premature babies and things of that sort. I don't think that I can have enough information right now to comment on it from embryo to live birth.
Yeah. Okay, awesome. So my last question around cord blood banking is, if a parent asked you if they should consider cord blood banking, what would be your opinion?
Yeah, I mean, I think it's definitely something to look into and do your own personal research about. I think technology is improving, and not just about cord blood banking, but I think technology is just around health and healthcare and cancer treatments, and not just cancer, for autoimmune things are expanding. And I think we don't know where things are going to go the next 20 years, but things are changing significantly for the better. And if it's something that they're comfortable with, having the options, I think are important. Yeah.
Okay. Awesome. Well, I'm really excited about today's episode because I actually have a large personal interest in LGBTQ and colored communities and sort of how they interact with healthcare, because I think a large part of cord blood banking is the fact that colored communities generally can't access a stem cell match as easily. So cord blood banking is a sort of a potential solution to that. So it's definitely super relevant and something that I spend a lot of time thinking about. And that's sort of the theme of today's episode. So I'd love to chat about this study that we found in 2021. A study was published in Fertility and Sterility, and they examined IVF success rates by race using data from the Society for Assisted Reproductive Technology. And the study found lower live birth rates for Black women versus white women undergoing IVF. So I'd love to get your take on why this disparity occurs and sort of where you observe racial disparities when it comes to fertility treatments in general.
So a little background. So SART, Society for Assisted Reproductive Technology, so that is basically a collection of data. And so fertility clinics need to report their data. There's different places you can report to, but SART is kind of the most well-known one. And it's useful because patients can also go to that website and say, hey, OC Fertility, what are your statistics for pregnancy? But in the reporting, one of the boxes that we need to fill out is the patient's reported race. So in part of it is that there is could be some reporting bias, right? Because that's also requiring practices to document the race. And so you can say unknown for some of them, but you there's always some bias in there. However, it is important to take a look at it, because when looking at this, they looked at, I believe it was Asian, Hispanic, Black, and white. And then they also looked at causes of infertility. So unexplained is a big one. There's things like PCOS or anovulation is one. There's uterine factor, things like fibroids, and then there's tubal factors if somebody has blocked tubes. And what they found is that Black women had a greater percentage of them with infertility had uterine factor. And that's interesting because, we know that, there is an association of fibroids with African American women. And I think that is partially contributing to it. But I think the other thing might be access to care.
Okay.
Right. So looking at, different ethnicities and races and populations within the country, also understanding, what is their access to fertility treatment?
Right.
Are there any barriers to it? Is it geographic? Is it financial? And, another important thing is age. And so although, all these studies have age matched controls, it's a different prognosis for a 32-year-old who's been trying for 4 years versus a 32-year-old who's been trying for exactly 1 month, for exactly 1 year, because they met the criteria. So I think that is an important thing to consider. And I think hopefully we'll gain more information over time as we're being more intentional about doing these studies, and with, hopefully providing more access to care. I think hopefully we'll be able to break down some of the barriers.
Yeah. Okay. Super interesting. I'm curious if you have any recommendations for parents of color, any precautions that they should take or things to look out for if they're looking at doing a fertility treatment.
I mean, I think the first important thing is feeling comfortable in where you're getting treated. And the second, I think, is finding a support group. And it doesn't necessarily have to be a support group, but finding support. And for many people, it's an online community. I have many patients who have, whether it's Facebook or other online supports, or sometimes just social media, listening to videos, hearing people talk provides comfort. Because I think that's an important thing, because, a barrier to care is geographic and financial, but it's also, taking that first step and walking through that door. And I think that's important. I also think, I'm Indian, and I identify as being Indian, and in some things I feel more comfortable talking about things with other people who are of a similar culture. And if that is how some patients feel, I think that's also important.
Yeah.
But I think I would offer them the same advice I offer everybody, in that seek consultation earlier rather than later. Just because you do a consult doesn't mean you have to do treatment. We're not there to pressure anybody into anything, but the more you understand your options, the better.
Yeah. Okay. Awesome. Good tips. Okay. Awesome. So I'd love to move into sort of a question category that we have on fertility as a person of color. So I'm curious if you have seen a certain ethnicity be the most fertile.
So, I mean, the term fertile is a little bit hard to answer. If you look at the March of Dimes data, right? When they talk about fertility, they're talking about who are more likely to conceive and more babies born. And if you look at that and they break it down by ethnicity, it's Hispanics and African Americans. But the term fertility is different when looking at, from an infertility aspect.
Right.
And so, I think it kind of also goes back to underlying etiology. Uterine factor is a little bit harder to treat than somebody who doesn't ovulate, right? Because uterine factor might require multiple surgeries to remove their fibroids and things. And again, a successful outcome for somebody with a uterine factor might be the need for a surrogate or gestational carrier. And that is clearly a much bigger, economic difference than somebody who just doesn't ovulate and needs to be on a medication for 5 days that gets them to ovulate. So it's not a very clear answer, but
okay, interesting. Why is it that Black women tend to be correlated with more uterine complications?
Not uterine complications. We're just talking about like uterine factor issues, fibroids. So, I mean, fibroids are very common. Women of reproductive age, women of reproductive ages are more likely to have fibroids, right? Especially in your mid to late 30s, we're more likely to see fibroids. And so there are people who are walking around who have no idea whether they have fibroids or not. But there is a slightly higher association. I mean, based on those studies, that they have more uterine factor.
Okay. Do you believe that race plays a role in fertility in general?
I mean, I think it does. You know, it's also biology and diversity.
Yeah.
Right. And that all plays a role. And I mean, it's kind of the same thing when you look at studies and they categorize people as Asian. Well, you know, I grew up in a town where you could very clearly differentiate between Vietnamese, Korean, Filipino, and Chinese.
Yeah.
Whereas in the studies, they're just Asian. And if somebody who is Filipino, their biology is going, and their DNA is going to be very different than someone who's Chinese.
Right.
Right. And the same thing, you know, for African American patients. Right. I mean, are you including people who are coming from Ethiopia the same as coming from South Africa, or versus people who've had generations here in the U.S.? So
yeah,
I do think that race plays a role in things, and I think there's also socioeconomic factors too that play a role.
Okay. I know that you mentioned that it's hard to identify which ethnicity is most fertile, but a really commonly searched question on Google was, are Latinos most fertile? So do you kind of have a reasoning for why people would tend to think that, or do you believe that there's any truth in that?
I think it's hard to say. I mean, if you just look at the statistics, you know, yes, there might be more people born to people who are Hispanic, but I think that could be cultural, right?
Yeah.
Different cultures will start to build their families at different stages. But you know, I did read an article talking about how the percentages of babies born to Latina women is less now than it was previously. Why is that? Well, maybe because more people are, you know, becoming educated. Contraception is more widely available and things of that sort. So, I mean, I think there's a lot of factors that go into it.
Okay. On sort of the opposite end, are there any demographics that tend to have a lot of infertility?
Again, there's bias in that, right?
Yeah.
I would say the Caucasian demographic. But that's, you know, but they also have more access to care in many cases, right? So there's more percentages. And if you know, even the study that you mentioned, if you looked at the number of subjects included, you know, it was significantly higher amount of Caucasians versus African Americans or Latinas.
Okay, interesting. Let's see. A lot of them do kind of inherently have bias on the question.
Yeah, I'm also trying to, you know, I'm also trying to not be so direct about things that there isn't a very direct answer to.
Right.
And I'm also trying to be thoughtful about not saying something that would.
Right.
Because, yeah.
Yeah. I guess something that I'm curious about, especially because I'm the product of an interracial couple, is like, is there some sort of fertility correlation with interracial couples, or is there anything that in particular you look out for when there's an interracial couple coming to you conceiving?
No, I mean, not that I've read about or seen.
Yeah.
I mean, if anything, you know, there's biological heterogeneity and diversity. So a big part of fertility, of the fertility consultation is genetic carrier screening, right? Genetics. And so we're looking to see, you know, is person A genetic carrier for diseases that they can pass on, and is person B a carrier for the same thing, right? And when patients are of the same ethnicity, they might be more inclined just statistically to be carriers for the same thing, whereas they're ethnically diverse, they're less likely to. We still recommend, regardless of their partner's race, to still get the treatment, but in one way that's a benefit.
Yeah, my mom always kind of had this inherent bias that mixed kids would tend to have less like disease or ailments. Like she attributes the fact that I'm mixed to like why I don't have any allergies.
I mean, it's possible, right?
Yeah.
We're diversifying the, you know, but I mean, you can argue that as society continues, we're becoming more and more diverse.
Right.
And so hopefully we get healthier if that is true.
Yeah, definitely. Okay, well, I think one thing that's super interesting to me is just maternal mortality in general, and also birth rates. Like there's been a lot of discussion, especially recently, around birth rates declining in the US. So I'm curious, is the Black birth rate declining, and how do you think if there is a correlation to sort of like maternal mortality patterns or just like general lack of care in the US for women? What's your take there?
Yes, the Black birth rate is declining a little bit.
But birth rates are declining kind of across the board.
They are, yeah. But if you were to, again, these like based on March of Dimes data, if you look at, you know, and their years are, you know, like in 2-year blocks, and most updated that I could see was 2021, but the statistics go down a little bit year by year. And I think that some of that, again, has to do with access to things, maybe access to contraception, access to emergency contraception, for patients being more intentional about delaying family building, things of that sort. And I think that's all playing a role in it. And I think, maternal mortality, I think, also affects access to care as well. And good prenatal care. As I mentioned to you offline, I trained in a place where, we saw a diverse population of patients, but we did see patients who didn't necessarily, even if they had access to care due to other extenuating circumstances, weren't able to make it to their appointments or to follow up or to do the things. And so I think that's all part of it.
Yeah, that makes sense. Do you have theories as to why the birth rates in the US are declining in general?
I think it's a combination of people delaying childbirth. I think, again, I think patients may be more intentional about, or people may be more intentional about when they want to start a family. I can't speak for all communities, but what I see in the community that I am and I treat patients in is that people are being more intentional about when they want to build a family. And so that's where fertility treatment comes in, because they'll say, hey, I'm with this long-term partner. We want to build a family, but we're not ready to. So let's talk about ways that we can preserve our fertility so that way in 3 years when we are ready, right? Whereas previously the answer would be, well, if you want a family, start now.
Yeah. Okay, awesome. I'm curious in general, because Jennifer, who we spoke with on your team, mentioned that you had sort of an affinity for DEI in the fertility space. What about DEI in general in fertility do you tend to focus on, and like what aspects do you find the most interesting?
Yeah, so kind of as I mentioned, I grew up in a very ethnically diverse place. I identify, with my culture of being South Asian and Indian, and I currently love where I practice, but it is less diverse than in other places. And I think that's just important, because when you're going through something as vulnerable and intimidating as fertility treatment, sometimes having exposure to other people in a similar situation you may find it calming and comforting. And I think that an important aspect of fertility treatment that's really not discussed as often is that the number one reason people aren't successful at fertility treatment is because they quit. And what are reasons that people quit? They feel defeated. Maybe, right? Or they're overwhelmed. And obviously, yes, finances is a big thing too. Yeah. And so I think, to me, it's just important that everybody has the opportunity and everybody feels welcome. And because, as I mentioned, I identify with my culture and I do feel comfort in talking to others of that sort. I think that's just important to me. Yeah.
How do you define quitting? Like not doing a second IVF cycle?
Yeah. Or, And it, doesn't necessarily mean that you have to do it with the same provider. You can, if you weren't happy, you can go someplace else. But yes, I think for people, if it doesn't work one time, it doesn't mean that it won't work the next time. Yeah. But we just need to continue to try. And yes, you can take breaks and such, but that's really what it is that IVF, or whether it's insemination or whatever it is, they don't go back to treatment.
Right. Okay. Awesome. Let's see, we have this other study that we wanted to cover that found racial differences in biomarkers like AMH levels, which are used to estimate ovarian reserve. This study in particular found that Black women had lower AMH levels on average than white women, even when controlling for age. So what are your thoughts on whether this warrants further investigation into potential impacts on ovarian aging across ethnic groups? And just like what was sort of your take on this in particular as ovarian reserves within different ethnic groups?
Yeah, so just a quick background. What do we mean by ovarian reserve? So as women, we're born with all the eggs we're going to have, and over time we're losing eggs, regardless of what we're doing. Getting pregnant, not getting pregnant, etc. And one marker of that is something called the AMH, or anti-Müllerian hormone. So it's it's a marker that's secreted by our resting follicles. So the greater the number, in theory, the greater number of resting eggs you have, i.e. a greater ovarian reserve. And what the studies have found is that although that's a very helpful number, that doesn't really dictate someone's fertility. So somebody could have, you can have two people and one can have a much higher AMH than the other. And it doesn't mean that if this person tried to conceive today that they would get pregnant pregnant over the other person.
Right.
And so although this is helpful to understand, it doesn't actually tell me, this isn't to me saying that, you know, women of one category that have categorically lower AMHs are less likely to conceive. But yes, it could mean that they just have a lower ovarian reserve compared to other groups. And I just think that we just need to continue doing more studies. And I think truly, again, one can argue, okay, well, who are the category of African American women who are doing fertility treatment in comparison to those who aren't? Is it that they're in a different geographic location, in a different socioeconomic status? And do they have access to things that other people don't, right? Because we know there's other things that affect fertility that aren't, you know, just smoking, et cetera. There's things like endocrine disruptors, right? And so here I am talking to patients on a daily basis. Okay, try to minimize your plastics, use stainless steel, use glass Tupperwares, things like that. Whereas there are other people who may not be in a position to be able to do those, and that may be affecting things. And so is it those things that are affecting things just as much as their race? I don't really have the answers to say that, but I think those are things that we have to continue to investigate.
Yeah. I feel like when it comes to ethnicity's relationship to fertility in general, there's sort of a lot of data missing. So I'm curious, if you were to invest in sort of one area of research in this field, what would it be? Where do you feel like research is most needed?
I mean, that's a good question. I don't think I can say where it's most needed, but I can say an area that's interesting to me.
Yeah.
Right. So just to clarify, like race, it has to do with ethnicity has to do with cultural identification, right? Race has to do with, you know, you could say demographic information, whether you're Indian, Chinese, African American.
Yeah.
And to me, I actually am interested in what your ethnic association does, right? Because is there cultural bias in how you identify, right? Because there are people who may be Indian or may be Chinese, but they don't identify strongly as being Chinese or as Indian. And are those people more likely to use a surrogate over somebody who does? Because I think that all fits into outcomes, right? Because again, people who don't feel comfortable, because for some people the next step, or what may be the difference between being successful versus not, is using a donor egg or is using a surrogate, right? And if they just don't feel comfortable, if they're unwilling to do it, then that's considered, you know, not being successful. And is it their ethnic associations that are affecting that? Oh, I think to me that's interesting.
Okay, cool. Awesome. Well, I'd love to move into our next segment, which is menstruation in people of color. So yeah, I'm curious if you have seen ethnicity affect the menstrual cycle in general, or even things like prevalence of sort of like related issues like PCOS or endometriosis.
Yeah, so there is some genetic components to both.
Yeah.
And you know, PCOS is polycystic ovarian syndrome. It's when patients will have an overproduction of androgens, right, which are male hormones. And it's harder to diagnose in certain ethnicities if you're just going on clinical symptoms, right? Because if you're lighter skin and have darker hair, you may be perceived to have more facial hair than somebody else. But yeah, I mean, there are some ethnic associations, like the Hispanic population might have a higher association of PCOS, but we're also seeing that if it's not just PCOS, if somebody is overweight, they will have anovulatory cycles, right? And if that patient comes in to be treated, they're more likely to be successful, because in many cases that's an easier problem to fix. And so in terms of menstrual cycles, it really just depends on the underlying etiology. So patients with large fibroids or uterine factor issues might have worse periods than others. But what we do see is onset of puberty does vary with race. And so when you're talking about, you know, as part of being a fertility doctor, you have to be trained in endocrinology, and puberty is part of that. And so when just looking at the different guidelines, you have to, like, one concern is someone starting puberty too early. It's called precocious puberty, but there's a different age cutoff for African American girls versus non-African American girls, because they will oftentimes start puberty earlier.
So what are those cutoffs?
So for African American girl, if they have breast development before 6, and for Caucasians before 7.
Oh, wow.
But it varies, right? Because if somebody, you know, if that child is a little overweight, they may have breast development that isn't true breast development. So it's a little bit confusing. But
why do you think those sort of differences in puberty occurs?
I mean, I think that kind of goes back to the question of race. How does race play a role in it? But, there's also, again, to keep saying it, but socioeconomic factors. Mm-hmm. So, if you read some textbooks, it'll say there's a certain weight that in order to trigger the brain to start producing the hormones to initiate puberty in girls, need to be of a certain weight. Yeah. And so if girls are overweight, they might have signs of puberty earlier. Right. And who's more likely to be overweight? Maybe people who don't have access to the same things that other people do.
Right. So what ethnicity sort of hits puberty first? I know you mentioned Black communities tends to be a little bit earlier.
I mean, a little bit. Yeah, it's not necessarily that a certain ethnicity hits it first versus others, but yeah, it's not uncommon to...
Right. Okay. What ethnicity hits puberty last?
I don't think I know the answer to that one.
Yeah.
I think that one varies.
Right. Okay, awesome. How have you seen different cultures treat menstruation in general, or just kind of think about it?
I don't think I can answer that about many different cultures, but I mean, I can speak to my own, and I think it's changed. I mean, growing up, it was maybe something you didn't, you talk to your mom about, but didn't talk to your dad or your brother about. And, there are times where, we have many religious holidays and things, and sometimes we'll have like a religious gathering at your house and you'll have to, help set up. But if I was, menstruating, my mom's like, nope, you don't do that. I'll do that. And kind of thing. So I think it's changing, but I think it's less of something that I think it's thought of as, less of something that you don't talk to your dad about. If you will.
Definitely. Okay, awesome. Well, I'd love to chat about LGBTQ conception and sort of methods of conception for those communities. Because I think especially when it comes to fertility, that can always be just sort of an interesting conversation for people in those communities. So what would you say are sort of like the most common fertility options for folks that are in an LGBTQ relationship?
Yeah, I think it depends on the relationship. If you're a same-sex female, you have different options than if you're in a same-sex male relationship. Yeah. So, but same-sex females, they have a lot of options actually. So to start, they can do donor sperm insemination, right? And so they can get sperm, and whereas different couples, heterosexual couples, may have the opportunity to have intercourse at home, same-sex female couples don't necessarily have that, and so we take their natural cycle and just inseminate them with the donor sperm. Right. They also have the options of doing IVF, as anybody does, but they have something called reciprocal IVF, in which you have two partners, let's call them A and B, and partner A, we can use her eggs to retrieve them, make embryos with the sperm of, a donor, however, and then we can put the embryo back into the other partner, and vice versa.
Is that common?
Yeah.
Yeah, interesting.
Yeah, and it's, every couple has their own goals, and some, within the couple will say it's really important for me to carry a pregnancy, and whereas another person might say it's really important for me to have a baby with my own eggs. Right. And other couples will say we just want a baby, we're happy however.
Yeah. What do you think makes reciprocal IVF so popular? Is it kind of like both partners want some sort of involvement?
Yeah, I think it's a beautiful way to build a family. Yeah. I also think it's, from a statistical outcome standpoint, you have, double the opportunity, if somebody maybe has the uterine factor, but the others has a better ovarian reserve than the other. Yeah. And so it's a way to kind of, cherry pick, if you will.
Yeah. Yeah. How common is surrogacy for LGBTQ parents?
Well, in the same-sex female couple, I mean, anybody has the opportunity to use a surrogate. For same-sex male couples, it's obviously very common. Yeah. For same-sex female couples, I would say surrogacy is probably as common as it is for other couples.
Right.
Yeah.
Okay, awesome. Can a child have two biological mothers?
The way that we are doing IVF now and for the foreseeable future is that if you're purely talking about DNA, the egg will come from one of them. However, you technically can have a trans female who donated sperm to that egg, and then you can have two biological mothers.
Yeah. I remember reading this article, I forget exactly what it is, but the embryo essentially had DNA from 3 parents because I think they had used
mitochondria.
Yeah.
That was something that they were doing in Canada and Mexico, where it was kind of like a mitochondria transplant, if you will.
Right.
Because the mitochondria, if you remember back to like high school biology, is the powerhouse of the cell. And so the thought was that it was called like 3-parent IVF. And so they would take the mitochondria from a younger egg and put it in. That's not something that is really shown to be as effective for outcomes.
Okay.
Perhaps in the future, but currently no.
Yeah. Why would people do a mitochondria transplant?
Because the thought is that it's the younger egg is going to have a better functioning mitochondria to help support the older egg.
Okay, interesting. So you could potentially maybe not have 2 biological mothers, but have DNA from 3 parents.
Yeah. Yes, but that's not something that that's not something that we are really, that was something that like in 2015, somebody tried, but it's not something that's frequently done.
Okay.
Yeah.
Interesting. Can 2 women have a baby without a sperm?
No, we need sperm.
Yeah. Okay. And then another commonly asked question was, can 2 women mix their eggs?
That is a good question. The way that we, when we do IVF, it's called chain of custody. We need to know where things are coming from. And so whereas, you can have an egg from one partner and a sperm make an embryo, and an egg from another partner make an embryo. Right. We know where things are coming from. Yeah.
So I would assume same for 2 men who want to have a baby.
Sperm, yeah.
Okay. What is the cheapest way for parents who are LGBTQ plus to have a baby?
The most inexpensive way for same-sex female couples would to do just donor sperm insemination. Yeah, we can, minimal medicate, like no medications, your natural cycle and inseminate.
Right. Okay. What about a same-sex male?
Same-sex males, that's a little bit less, less cost effective, but they would need a donor egg.
Yeah.
And a gestational carrier or a surrogate.
Okay. Awesome. I'm curious, what are sort of like the most innovative or kind of wild approaches you've seen to LGBTQ parents conceiving?
I mean, I wouldn't call anything wild, but I mean, there's many ways to build a family.
Yeah.
Right. And so I think let's talk a little bit about donor sperm. Okay. It can be done 2 ways. One is an anonymous or de-identified donor sperm, in which somebody has produced a sample. It's at a sperm bank. All the legal stuff is done. They've done the testing, and that sperm is theirs to use. And, the donor has no legal responsibility or rights. Right. But another way is a known donor. And let's say it's, somebody's cousin that's not genetically related to them, but a friend. We still have to go through the legal things to be done, legal, and you have to treat them like they're a donor, even though you know them. But what I haven't seen a lot of this personally, but I did read an article where you had a same-sex female and a same-sex male couple. They had the same goals of building their family, and they got together and did it that way. So the male was the known donor. Yeah. And so you still have to treat them like a donor, but it's not necessarily, it's obviously not anonymous, but they were kind of like a joint family.
So it was like one male from one couple, one female from the other couple, and vice versa.
Yeah, I mean, I this is not like a real life situation. It's an article that I read.
Yeah.
But yeah.
Okay, cool.
Yeah.
No, I mean, I feel like there's been more kind of discourse around like extreme levels of co-parenting, like kind of having like a communal space. So I feel like that could potentially be more common.
I mean, I can't comment on that, but there's many ways to build a family. Yeah. And I think it just kind of comes down to what's important to each person.
Yeah, definitely. Awesome. Well, our last sort of category of questions is around at-home ovulation and fertility test kits. I myself have actually done a lot of sort of analysis around companies like Modern Fertility, because they're sort of like far off but adjacent from what we do at Anja Health. So yeah, I'm really curious to sort of get your take on ovulation tests kits in general. So do you feel like ovulation test kits at home can be effective, and what kind of information would you recommend patients try to glean from it?
Oh yeah, I mean, I think that they're very helpful, and I advise anybody who's trying to get pregnant to try it. Now, each person's different. For some people, it works really great and it's very effective and it helps them.
Yeah.
And for other patients, it's really confusing.
Right.
And so basically the goal is to use it to time when you're ovulating to guide you when to have intercourse.
Yeah.
And not everybody who's trying needs it. I mean, the textbooks will say, if you're trying, have unprotected intercourse twice a week. Mm-hmm. And over the course of the year, you should hit your fertile window within the appropriate times. Mm-hmm. But for some people, that's not practical, or they don't want to do that. They want to be a little bit more directed. And that's where the ovulation predictor kits come.
Okay. Awesome. Can ovulation, so I guess then in that case, they can detect like windows of fertility, but also can ovulation test kits detect levels of fertility?
No, it's not necessarily levels. The only true test of someone's fertility is to try to conceive.
Okay.
And so in that regard, yes, if it tells you when you're ovulating and you have sex and you're not getting pregnant, yes, we can deduce from that. But the ovulation predictor kit is not going to give me enough information to say, this person is more or less fertile than that person, unless it's telling me that they're not ovulating.
Right.
If somebody is not ovulating, and the word fertile is weighted, right? It's, fertile to me means, well, given the right situation, put in the optimal guidance, would they conceive? Mm-hmm. And if someone's not ovulating, that's not necessarily. But yes. And so for some patients, it's really confusing because what ovulation predictor kit is testing is a hormone called LH. And that's what's supposed to peak and rise right before we ovulate. Mm-hmm. And for some people who aren't ovulating or who have something called PCOS, their baseline LH level is higher than somebody else's. And there's so many different kits. Some will say detect your surge a few days early, etc. All that means that they have a lower threshold, right? Yeah. And so if your baseline level is higher than that threshold, it's going to show up positive all the time or irregularly, and it's going to be really confusing.
Yeah.
So for some people it doesn't work that well, but for many patients it works really well.
Yeah, super interesting that you say the best test for fertility is to just try to conceive. So like, are there no other indicators or like anything you can do to sort of detect like for instance, I feel like the sell with modern fertility was like, if you're in your 20s, you should be able to gauge like where you're at, if you don't have a partner or anything like that. So do you feel like that's just like false hope?
It's information is information, right?
Yeah.
But the key is, what do you do with that information? Mm-hmm. That's what matters. And so what I always tell patients, because we'll have patients who come to say they're thinking about freezing their eggs, and we do get an AMH. Yeah. The goal of the AMH is to guide them to say, hey, if I were to give you medication to freeze your eggs, how do I think you're going to respond, to manage your expectations? But if your AMH is on the low side, and you went out and tried to conceive within the next 6 months, that doesn't tell me you will or you won't.
Right.
Because there's people out there who are conceiving quite easily, and we don't know what their AMH levels are.
Right.
They could be low. And so while those tests are helpful, that's not truly testing someone's fertility. Yeah. It's just really, just to call it what it is, it's just a testing your ovarian reserve. And even then, you need multiple pieces of data to create a slope of a graph.
Yeah.
And so I don't know that, you could be 32 and have a low AMH, but maybe in 2 years it'll be very comparable versus somebody else who has maybe a little bit higher of an AMH, but in 2 years it'll be a lot lower because, each person is not the same.
Yeah. I feel like in media, I've seen a lot of scenes where a doctor will say something along the lines of like, you have the uterus of like a 25-year-old.
Yeah.
So,
yeah.
Is that just like media only?
Kind of, yeah. I mean, what I could, patients will say, oh, my doctor said I have the ovarian reserve of a 40-year-old and I'm 30. That is not as easy to say because I have 40-year-olds with very robust ovarian reserves and get more eggs than my 30-year-olds.
Yeah.
So it's not as, linear of a correlation, whereas egg quality is much more correlated to your age than egg quantity.
Okay. Super interesting. Sort of related, but out of this specific realm, but I've seen also some companies advertise, for instance, like, we can test your hormones to help you decide what type of birth control you might be less reactive to. Do you feel like there's accuracy behind those claims? I'd probably have to see exactly what hormones they're looking at. Yeah. But I think that, birth control, there's many different formulations of birth control with such subtle, there's so many different types of progesterone, so many different types of estrogens with subtle changes in the dose. I think for some patients, it's a little bit of trial and error. They might need one that's a lower dose than another or higher dose, et cetera. Right. Okay. why should you not use first morning urine for an ovulation test? That was a commonly asked question.
Yeah. So the hormones that are produced to act in our ovary are produced by our brain, and it's cyclical. And so what the textbooks will tell you and what the data shows is that when we have our LH surge that's going to induce ovulation, the majority of the time that'll occur in the middle of the night, sometime between 12 and 8. And if we're looking for that level in your urine, your first urine, it may not show. And so that's why testing for in the afternoon, you're more likely to see it.
Okay. Can too much urine affect an ovulation test?
I mean, not too much urine, but the key is that, if you have an excessive amount of water immediately preceding, it's possible that it could dilute it a little bit, but I don't think that too much urine is going to make a difference.
Okay. Is it best to take an ovulation test once or twice a day?
So there's not really an improved outcome by taking it twice a day over once a day. I mean, the key is that if you're taking it every day, you should hit your surge. For some cases, you'll hit it 2 days because it's a peak. It's going to go up and it's going to go down, depending where you're testing. But if you do it twice a day, is it possible that one of them will be negative and the other will be positive? Yes, but if you're doing it every day, you should still get the outcome.
Okay. Why do you have to wait 4 hours to take an ovulation test?
Well, it's the same. I think that question is similar to why can't you do it in the morning?
Yeah. Okay. Do ovulation test strips work for everyone?
There's some people that it's not going to be straightforward.
Yeah.
And I also think it depends on what kit you get. I personally tell patients the less complicated it is, the better. But I like the digital ones better because then patients are kind of staring at it saying, is it dark? Is it blue? Is it light? Versus the digital one where it's kind of like positive or negative.
Yeah.
But there's some that flash, some that don't flash. I just say keep it simple.
Yeah.
Because the flashing one isn't going to flash forever. What if you put it down and get on a Zoom call and come back and you don't know if it stopped flashing because it was done or because it never flashed? So
yeah. If someone is looking at ovulation or fertility test kits in general, do you have recommendations? I
mean, I don't have an allegiance to one brand or another. I personally have liked and used the smiley face ones, not the ones that flash, the one that's a blank face or just a smiley face.
Yeah.
Because it's straightforward and I'm not overanalyzing it.
Okay, awesome. Well, do you have any general tips for parents of color or even LGBTQ parents that are currently trying to conceive?
Yeah, I mean, I think that, the one thing I talk to patients about is that, again, the only test of someone's fertility is to try to conceive. And so many patients in, same-sex relationships don't have the opportunity to come in with that data saying, hey, I've been trying to conceive and I haven't. So the thought is for many patients that I should get pregnant pretty quickly, but we don't have any information about that. And so the recommendation that I would give to patients is don't just wait until you're absolutely ready because we don't know what's going to happen.
Yeah.
Right. And it's harder to make decisions because, every data we have about you trying to conceive is based on treatment. And so whereas somebody else might try for a year and then come in or 6 months and come in, for some people that's doing, 6 cycles of taking medication and insemination, which takes a toll on you.
Yeah.
And so, I'm not advertising that people need to try to conceive before they're ready, but do take into consideration, especially same-sex female relationships, with age.
Yeah.
There's studies that show even for patients who use donor sperm because their partners had no sperm, the pregnancy rates with age really did decrease, even though presumably that person should be fertile.
Yeah.
And so age really does make a difference.
Yeah. Thinking about sort of preparing for kids, I read an Atlantic article that was published last week around the fact that if you have basically repeated like ejaculation inside of you prior to conceiving, it can potentially lower your chances of preeclampsia. It was kind of like a controversial take, and they were even saying that like it's just generally not the most accepted opinion, but like some believe that continued exposure to the other parent's sperm can sort of help with like a potential immune response or like reduce the complications later. So do you kind of have a take on that?
No.
It was kind of a viral Atlantic piece.
Totally. I wish I could come up with something. Sorry.
No, it's okay.
Not going to be in there. Sorry. I mean, I can kind of make something up, but it's not going to be worth it,
Yeah. Okay, awesome. Well, if people want to find you, I know OC Fertility, Sharon mentioned that you can sometimes take patients even outside of the OC area.
Yeah,
With
totally.
telehealth, for instance. So, yeah, if people want to find you, how can they get in touch?
Totally. So social media wise, my Instagram handle is at Dr. Nadhee Sachdev. We also have a OC Fertility one. It's actually Orange County Fertility. But yeah, our practice is in Newport Beach. It's a beautiful location. We love where we are, and we see patients in person and telehealth. And I mean, it really just depends on what we're doing. I mean, we see many patients who live outside of Orange County, who live in different parts of the country. And, we have so many patients who are like, I live in New York, but, my parents live in California. So I'm going to just spend 2 weeks there and I'll come freeze my eggs and I'll go back, things of that sort. So, we're happy to see patients wherever they are.
Okay, awesome. Well, I really appreciate you being here today and answering so many of our questions. So yeah, thank you so much.
Awesome. Thanks for having me.